I'm on YouTube. I think we're on YouTube now, uh, and I am getting on TikTok. So you can hear me, okay?
Yes, I can hear you, Doc. Yeah, we are live on YouTube now too.
Hey, everybody. How are you? Welcome back to our regularly running live. I guess what do we call this podcast, Parham? It's
Yeah.
me and Parham Namatola. Thank you guys for coming on. The topic today is going to be: is it benzodiazepine taper or detox? Is that what we're calling
Detox,
it?
yeah.
Yeah, benzodiazepine detox. And as usual, we uh, invite everybody to come on and ask their questions, whatever the questions are. And I'm here with Parham Namatola. He apparently a lot of you guys have been asking about him when you call. That's going to be his choice how he handles that, but it's him and Nicole are working it out. And as always, please go. I guess you're saying you use Instagram more than anything, Parham?
Yeah, on Instagram, it's the 1 minute therapist. It's little short 1 minute videos I've created to help people change the way they think, the way they feel, the way they behave. So uh, that's pretty much what it is right now. But hey, everyone, what's up? If you're watching this on the state side of things, I hope everybody had a fun, safe 4th of July. You had the opportunity to spend some time with some friends, family, loved ones. Looking forward to another week. I know we've had a few similar videos, but it seems to be the one that there's a lot of interest because there's a lot of human beings that are struggling with the symptomology of the detox and taper and withdrawal and all that kind of stuff. So hopefully we will be able to provide some information and provide some support to you. So on this one, if you're watching this and you do need to talk to Dr. B and I, feel free to join the stream by clicking on the link that Nicole is posting on the chat. So the one that says Real Talk Recovery with Nicole, she leaves a little link on the side. And if you click on that, you can come on and talk to Dr. B and myself. So looking forward to being there, supporting whoever we can, however we can, any way we can.
Real quick, Parham, let me just tell we just got on TikTok. Hey, guys, I didn't make an earlier announcement. Today's topic is, we think it's a popular one, benzodiazepine detox. Is that what it is? Yeah, it's benzodiazepine detox, taper, whatever. Me and Parham Namatola, as usual, we are on YouTube. The channel is Dr. B Addiction Recovery. You can go on there, ask your questions. I always keep the TikTok live just in case someone wants to just hear it. Hopefully, this connection works well. And thank you for having a thank you button. Uh, so you guys can go on there and talk to us. Okay, Parham. Wow, this looks like a popular one, huh? Yeah, I always get. I get. In fact, I just had somebody from. God, where was it? Nicole, where did we at? We get people from other states that fly in just for a consult on this issue. But tell us how to start. How do you want to start this, Parham? Sorry, guys. I have a clinic today, even though I'm in regular clothes, and I have 60 million things going on. But we're both trying to stay really committed to making this thing happen. So forgive me being scattered. Parham, how do you want to start this?
I think it should probably be something from your direction, if that's okay, because it is your scope of practice, and I'm assuming maybe some of the side effects or some of the common symptoms that you see in the withdrawal in the detox process. People getting off the medication too soon, or somebody having a hard time with being on it for a long time and then abstaining from it for a period of time, however, experiencing certain symptoms. Whatever you've seen from your professional experience that might be pertinent or relevant to the audience today. And I can definitely come and talk about the underlying issues related to mental health and managing anxiety and possible healthy coping skills that may be able to help. So I think together we'll be able to accommodate any type of questions that may arise on the topic.
Sure. I'm going to probably be a little long-winded on this one.
Yeah.
And give a big picture of it. So rule number one, if I may, let's go through the history of benzos and the long-acting ones. First one was in the 50s or 60s, but kind of a truncated history up to the '70s, benzo is a class of drugs within the bigger umbrella of sedative hypnotics. Okay, and what used to, in general, okay, guys, if you want details, we can go into details. But in general, before benzos, we were using barbiturates. Okay, now barbiturates are great drugs. Okay, and these all pretty much kind of hit the same receptor types, but the different mechanisms and so forth. Barbiturates are great drugs for sedation, muscle relaxation, amnesia, pre-op, all this stuff. The problem with barbiturates, okay, is that they have what's called a narrow therapeutic index. And what that essentially means, the dose that you need to get the effect that you want on a curve is very close, that window, that curve area that is therapeutic. Just above that is your toxic dose, overdose dose, et cetera, et cetera. Okay, that's the problem with barbiturates. Okay, and from the '70s on, in a kind of international kind of way, Valium and so forth kind of became the darling of the safer way to go about things, and they sure marketed the shit out of them. Okay, every housewife on the planet was on this stuff, and it's non-addicting. Okay, it's go back and look at some of the ads. Well, let's move it all the way up to the last 15, 20, 30 years. What eventually happened is as the medical industrial complex sort of became, doctors no longer, we're making tuna cans, okay? So everybody started to get on benzos and Xanax and so forth. In truth, and this is after we knew it's addicting, in truth, benzos are meant for short-term use. And anytime you prescribe a class of drugs like opiates, like benzos, a lot of this stuff, you got to really watch that patient, how they respond to it, how long they're on, and any evidence for abuse. Now, some of it was not their own fault, but, just a overwhelming number of patients, giving somebody Xanax for panic attacks and forgetting about it is sort of, what are you going to do? You got 10 minutes to see a patient. Long story short, we come all the way up to now, and you have hundreds of thousands of people that were on chronic benzos, and this is a drug meant for short-term use. Now we're dealing with sort of the aftermath of that, and so there's different groups of patients. There's the elderly patients that have been on it, the young guys that in this new whole generation of substance abuse that are abusing it, all kinds of patients. But in short, what we have now is the idea of detoxing off the benzos. Again, I think I have other videos on this, and I'm going to eventually get to this class. It's fascinating what we're dealing with out there. What you're coming across is people are being, most of the doctors that put these guys on the benzos, and let's say they've been on it for a few years, don't know how to take them off the right way, especially if it's what I call a complicated taper, which means in one way, shape, form, or another, without getting into the physiology and pharmacology, there has been a sensitivity developed to this medication. Now, whether it's withdrawals or whether it's long-term withdrawals, all kinds of stuff. And so what I'm getting at this point is that, I'm getting patients that just can't come off of it. And one of the main things that I see out there is that when someone's been on there on this stuff for a long time, you can't do a 5-day detox off of this and expect there to be no problems. It has to be tailored for each patient. It takes a very particular approach to that patient and some exploration with all of their other comorbidities and hypersensitiveness to this medication, in addition to their other mental health issues. And sometimes it could take up to a couple of years. Sadly, on the other hand, the payers don't really cover for this either, right? when you have detox facilities and so forth, what are you going to do? Get a 2-year detox going on? They yank them off because that's what they're supposed to do. So that was a really shortened version of this, but it's a complex drug with very, very complex issues for some individuals. And I think the elderly, it even gets more complex. And I would say, Parham, that the withdrawal off of this stuff, especially long-term withdrawal, or it's a nightmare. It is just yucky. It's not like heroin. Heroin is just sheer pain, and it sucks, and you want to jump out of your skin. But there's something about this stuff with the dysphoria and the long-term people, they get the hypersensitivity to light, to auditory, to skin. You could have hallucinations. It's just weird. So, a quick regular benzo taper for someone that's been abusing it short-term, one thing. But what I'm getting is a lot of people that the other physicians just aren't sure what to do, or they don't believe them. I had one lady, Central Valley, she was down to 90 pounds, and she had told the doctor she was going to go see me. And he told her I'm a quack. I don't know where he got that from. I'm a medical doctor. But, here we are a year and a half later. She's 120 pounds. Her life is normal again. We just slowed it down. But I get a lot of these issues. And I made it very short just because I'm not so talkative today. So that's what I have to say about this stuff. It's pretty interesting.
No, that was short but sweet. That was very well said. And thank you for giving a background on the history of benzodiazepine kind of development in our society, and now the impact that we're seeing, the wave that's hitting us from people that have been on a medication that was intended for acute cases on chronic anxiety. So I'll tell you this. So everybody watching here, Dr. B, obviously medical doctors, you could heard, he's very proficient on talking about benzodiazepine. For those of you who don't know me, my name is Parham. I am a licensed advanced alcohol and drug counselor. I do have a master's degree in marriage and family therapy. So when it comes to the mental health component of this, I want to share a few things that I've seen with individuals who struggle with benzodiazepines. So if somebody was placed on benzodiazepines, for example, as an adolescent, okay, and let's say they were put on it because they were experiencing significant amounts of anxiety, social anxiety, maybe they experienced some trauma in their life and they had some PTSD from a trauma that occurred to them, and they were dysregulated. They were unable to go to school and focus and pay attention and participate. Maybe their parents went through a really nasty divorce at an impressionable age for them, and it started to cause some sleep problems in them, and they started to have hard time focusing, concentrating, paying attention. And they go see a doctor, as doctor said, that maybe they don't have that much time to actually get into the underlying causes of where the anxiety is coming from. And they say, well, son, you're experiencing a little bit of anxiety. This medication is going to help you bring down your thoughts a little bit so you can engage in school a little bit. This is going to help you sleep at night a little bit. And what's happening at this point is they take the medication, and guess what? At first, it works. It does wonders for the individual. It takes away all of the negative symptoms they're experiencing. It takes away all of the discomfort that they're in. It helps them sleep at night. And as time goes by, because of the dependency nature of this medication and the fact that tolerance builds, I've yet to meet a benzo individual that. And Dr. B, I might be echoing a little bit on your computer, by the way. Yeah,
I might just a little bit. You're fine. And in fact, just real quick, the gal I was talking about, Central Valley, she's on here today. If she wants to, she can come on and share her experience with us. But
for
please
sure,
go ahead.
Yeah. So, as benzodiazepines, there's this thing called tolerance, which means you need more of the drink and more of the drug to get the same desired outcome. And people start to take more and more and more of the drug to the point that they're completely unable to function without the use of that substance. So I've yet to meet somebody that is taking 8, 12, 16, 20 milligrams of Xanax, and that was their starting point. Someone started them off with maybe 0.5 or 1 milligrams or 1.5. And through the process of not dealing with the underlying issues, they started to build the tolerance and they started to build the dependency. And now it's almost impossible for them to get off the medication without someone like Dr. B to personally tailor the detox. So when someone gets off the drug and they're going through the withdrawal effects and they say, I just want to get off this stuff, my work right here as a clinician just begins, because here's what happens. If you want to get off of that substance and you got on it originally because of some underlying anxiety, PTSD, some, just discomfort inside the mind, and you've yet to address that, the withdrawal process is going to be very, very, very difficult and hard. However, with the combination, so it's a multidisciplinary impact here. So with the combination of good guidance from a medical doctor who knows what he or she is doing, with a therapist that can go in there and work with underlying causes of your anxiety, with proper rest, nutrition, diet, and all that kind of stuff that we always talk about, the holistic route, it becomes a little bit more manageable or tolerable to help get off that medication. It's still not easy, by the way. So I'm just calling it what it is. It's still not easy to get off that medication. However, with all that, the odds of success significantly increase. So as people get up here, I will definitely talk about that stuff with, what was the reason you got on the medication in the first place, and have you done anything about that since trying to get off? So that's going to be my contribution to this conversation.
In fact, Parham, since you bring that up, I think I lowered it, Nicole. Since you bring that up, the other thing I've noticed along with this, I have a very eclectic group of patients with there's a complexity to each one of their issues that's very unique. But one of the things I realized through this issue and dealing with so many younger folks with polysubstance abuse, and tell me what you think of this, is we recently discussed adverse childhood events and stress physiology. And there's so much of that crap out there that's not recognized and addressed in a timely fashion. These folks are coming up and someone's just throwing this stuff at them, and we're dealing with the backlash and the consequence years later. I still always wonder, how are we going to get there? Because my prescription is, okay, we'll do this whole taper. I can manage this crap however long it takes. But you need good mental health. So I think the prevalence of this issue is even higher, as we've discussed, you and I, in the last show and before. Everyone's suffering from some sort of traumatic event in their life, and it sucks. And I think all of this is of epidemic proportions. Just wondering what your thought on that was.
Oh, yeah. I mean, we barely address the roots of this. I mean, for the common practices, let's just look at what symptoms they're experiencing, and let's try to get rid of the symptom. And if you're just looking at it from face value, it's like, okay, the individual might experience a little bit of relief. But what kind of relief is that? It's kind of like if you have a lot of debt and you get a loan from somewhere, and you pay one loan for the other one, and then you're still stuck with another loan with a new interest rate, kind of like you're making a different problem somewhere else. Eventually, that line of thinking is gonna come to a really bad explosion. So I agree with you. If anybody's interested in what Doctor just talked about, we did a conversation on the roots of addiction. And the roots of addiction significantly talks about what we're talking about right now. So the adverse childhood experiences, those are the exact reasons why uneducated physicians are going to put an adolescent or a child on something like benzodiazepine, because they don't have the time, energy, bandwidth, education, knowledge, experience, or even just the desire to find out what's actually going on with this person, because it might not even be their scope of practice. It might not be their duties or the requirements, which is that I think that's a flaw right there too. I think that they should be one of the first people that are screening for these kind of things, rather than just looking at the kid that has a hard time paying attention in school or has a hard time sleeping at night.
Absolutely. There's a boatload of people on here that were trying to get on.
Should I bring them on?
Okay. I'm going to hand this over to you somehow next week, because I can't.
That's fine. That's fine, man.
We got Crystal 1968. Crystal.
Hi.
Hi, Crystal.
Hi, how are you?
I remember you.
Yeah.
Yeah, what's up?
I just decided to join the conversation. I saw it on YouTube. I was just scrolling and stuff. I'm tapering 2 milligrams of clonazepam that I've taken for 31 years.
I remember.
Let me tell you what.
Oh, we lost her. She's going to come back. She's good.
I got her. Hold on. I'll get her up.
Okay.
Can you hear me?
ahead.
Okay.
Yeah.
Yeah, I'm having a really hard time with it. I mean, today it's like I tried to drive and I had a panic attack while driving. I had to pull over and all that stuff. I mean, this is just hell. I mean, really. And I look back, if I could go back to that doctor's office back in 1990, I would have walked out there screaming. I wouldn't have ever touched this stuff. But at the same time, I don't know. It helped me for so many years, or maybe it didn't. I know. I don't know. But I'm tapering now, and it just sucks. That's all I can say.
What what's your current dose?
My current dose, well, I was on 2 milligrams. I'm doing a 2-year taper. I'm about 40% off of a 50 milligram pill. So yeah, I'm dosing 50 4 times a day, and then taking 40% off the night dose.
Yeah, talk to your physician if you need to just slow it down a little bit. Slow it down, the way I look at it is this should be very comfortable. Who cares? 2 years versus 3 years. You were on this stuff 30 plus years.
31 years.
Yeah. So, I don't think that withdrawals of this stuff are anything of a cakewalk. So, but kudos to you. I think it's fantastic. But again, don't hurt yourself coming off this stuff. I do not believe a painful benzo taper. There's a psychological dependence to this stuff, and then there's physiological. Psychological, I can talk you through it. The physiological, I should let the medication do what it's supposed to, and you should suffer. That's more dangerous than the psychological.
Crystal, I do have a question for you. Since the last time you were on with us, I think it was like April, right? So it's been like 3 months. Since the last time you've been on with us, for the people watching, has your taper been better? Like, has it improved at all? Just to give anybody some idea of what it's like after 31 years.
I can't really say that it's improved because I'm still waking up every morning with the shakes and sweats, and my blood pressure's all over the place. I've recently been put on propranolol. I just got put on that this past weekend. It's helping a little bit, but I don't know. I'm just feeling very dizzy an awful lot. I mean, 31 years is a long time to be taking this medication. I often wonder to myself what it's going to be like on the other side, if I'm ever going to get to the other side. I mean, and my doctor that I'm working with, he wants me to do it in 2 years. I don't think it'll be accomplished in 2 years. I think it'll take at least 3. I mean, 31 years, that's a long time. My brain just feels like it's going in all directions right now. And I wake up with these night terrors. Sometimes I sleep 3-4 hours a night, and I wake up and I'm just terrified.
Yeah.
If I may give you a thought, let me ask you a question. Remind me, why are you coming off of it now? Was it your choice, his choice?
No, it was
Hey guys, hold up 1 second, Crystal. Do you have us on YouTube?
Huh?
Do you have us on 2 different locations? The stream is it on YouTube also? Can you close one of them?
I don't know. Let me see. What can I do here? How do I do it?
Because I feel like it's echoing back.
Okay, hang on.
It is echoing in.
Oh, we lost her.
I'll get her
I
up.
think it's
By the
coming
way,
from her side.
Parham, I forgot to announce. Because of the clinic I got going on, about 6:05 today, I gotta go.
Okay.
And I just so everyone knows that, and I apologize. But here, let me pull her back up.
Oh, that's Abe. That's someone else.
Hi guys.
Oh crap! Hi, Abe.
Wait, hold on. We have to get Crystal back on.
Hold on, Abe. Hold on. Oh, she's right there.
Okay.
Oh.
That's because I'm the 31-year benzo girl.
Okay.
Yeah.
No, we got you. My question was, whose decision was it? What is the reason you're coming off 2 milligrams of Klonopin? Remind me.
Because I'm being forced off.
Okay. All right. And so here's my thought on it. Again, in general, these are my thoughts. This is not medical advice. In general, 2 milligrams of Klonopin if there's never been any abuse, misuse, diversion,
Nope.
and you're optimally. So this is what I meant, Parham, when I said the situation's been created, right? They shouldn't have been giving these people this stuff more than 10 days. Okay, now, I get guys in my office, he's on, let's say, 1 milligram Xanax a day for the past 28 years. It's dumb to yank him off. The guy's a highly functional executive that's doing well. And, you talk to him, and you can tell his receptors aren't blown out. And at this point, one should not make a knee-jerk reaction. All of a sudden, you woke up and decided, oh, benzos are bad, so you can't be on it. That's not how it should be done. You should look at the person. Well, they're already in this situation, and some of these folks, you should keep them on, especially if it's not an outrageous amount and they're functioning well. And then other ones, very clear. All international guidelines. It's not rocket science. Let's say we do want to taper, okay? And we want to get it. You should always approach the taper with the idea, as a clinician, you should always approach the taper with the idea that we may not get to zero, but we will decrease the dose in a comfortable fashion, and wherever we land, we land. That's it. And all of a sudden, everyone's a knee-jerk reaction, get them off. So that's my thoughts on that, guys. And Crystal, again, I don't know your case. That doesn't necessarily apply to you. That's my risk-benefit approach to this idea of get everybody off of everything. That's stupid. We created this issue.
Once I got on the medicine, I turned into a fully functioning individual. I went to work. I drive. I was driving. I even had a job driving. I was fine. Now it's like I can't do half of what I'm doing.
Well, you got a good attitude. Just think about what I said. Talk to your doctor about it. I'm not giving you medical advice. And Parham, this is one of the things that, in this environment where this situation has been created, that's how I approach it, because they should have addressed this issue 30 years ago, right? And then now they figure it out. Okay, well, she actually is one of the good ones because she didn't escalate. And you know what? The other thing is this. Some people, not the way it used to be, some people do indeed clinically need the medication for life.
I have ulcerative colitis. And I can swear to God, back in 1988, the very day that my colitis symptoms started, so the panic attacks.
Yeah.
So I don't know what I'm going to do.
Crystal, keep us updated. What state do you live in?
I'm in Illinois. I'm 45 minutes north of Chicago.
Oh, yeah, I did some training in Chicago. Yeah, I told you. Keep us updated, and, talk to your provider. Look at all your options. Your provider is great at what they do. But something doesn't sound right here to me, and I could be very wrong. Like I said, I don't have all the details. I'm just giving you food for thought, consideration, and keep us updated, okay?
It's just one thing, one note before I leave. I'm tired of being looked at as a druggie. Now I'm looked at as a druggie. I'm looked at as a pill seeker and all this other stuff. I never, ever thought that being on this medication that I'd be looked at that way. I thought I was just taking my medicine.
Yeah, I understand.
I don't drink. I don't do other drugs. I don't do any of that stuff. I smoke cigarettes, but that's it. I can't drink because of my medical conditions. I can't take opiates. I'm allergic to them. In fact, that's on my charts in the hospital. I can't have opiates.
As a doctor, I recommend you quit smoking, okay?
Yeah, I have to. I got to quit smoking cigarettes. But yeah, as the anxiety increases, I want to smoke more.
Yeah, I understand. Keep us updated. And
I will.
I think if you're forced down this road, Parham especially can suggest some mindfulness techniques. They're very powerful, and so keep us updated. We wish you the best of luck. Did you subscribe to our channel?
Yes, I did.
Good. Keep us updated, okay?
Okay, thank you so much, guys.
Bye.
Thank you. Have a good day.
Okay. Yeah, I don't. Yeah, that's it. Let's get Jules up here. Then we got Eli, and then we got Abe. Jules.
Hello.
What's
Hi,
up,
Jules.
How are you?
We're good.
Good.
How are you?
I'm all right. Making it.
Go,
I
go for it.
guess. So, what do you tell me about the benzos? Because I've been on those for a while.
Well, what do you want us to tell you? You're the one that's supposed to have the question for us. Give us a question.
I've been on them for about 10 years, and they say that I should stay on them forever.
Okay.
I started out at the 0.5, and they prescribed me the 2 milligrams twice a day, but I can usually get by taking a half.
Which
Maybe.
one is it? What did you say? Ativan?
No, a Xanax.
And they prescribed. What's your dosing?
2 milligrams twice a day.
2 milligram bars of Xanax. Oh, and what's it for?
Anxiety, because anxiety and sleep. But I don't take it like that. I can get away with taking a half a bar sometimes.
Okay, it's an odd choice and a high dose for anxiety and sleep. Especially Xanax. I mean, I don't know enough about the medical history, and if you've been taking it for 10 years without any issues, I suppose it's okay. But it just sounds like an odd choice for either one of those, and to be on it for 10 years. And you would think of a longer acting one, and so on, because Xanax has much higher abuse potential than, let's say, some of the other benzodiazepines, just because it rapidly crosses the blood-brain barrier.
Yeah, I've heard a lot of scary stories.
Jules, can I ask you a question?
Yeah.
10 years ago, when you went to see your physician and you were experiencing some anxiety or sleeplessness, what was going on in your world at the time that you were experiencing those symptoms?
I was in a really bad relationship.
Yeah.
Really
so, without knowing anything about you or just the way that you phrase bad relationship, I have a feeling that as a result of that relationship, you started to experience a lot of what they call it's PTSD symptoms. Okay. So post-traumatic stress disorder, there's a lot of anxiety, there's restlessness, there's a hypervigilance, there's fear, there's a lot of worry, there's a lot of uncertainty. And those symptoms that you were experiencing 10 years ago were so high that they were causing you to have anxiety, possibly panic attacks, sleeplessness at night. So when you sought to see the doctor, they prescribed you something to help you with those symptoms. However, it's been 10 years right now. And not knowing much about you or your history, I do know that PTSD and trauma does not just go away on its own. So when left untreated, it doesn't just resolve and resolve itself. So even till this day, the medication that you're taking is still helping you deal with some of the damage and the wound and all that kind of stuff that was inflicted by that abusive, traumatic relationship you were in. So my strong recommendation or suggestion is have you ever sought out, let me ask you first before I assume, have you sought out to address any of the side effects of that relationship later on through therapy? And also, second question, have you found yourself repeating the similar relationships with anybody else since that time?
Yes to what you just said, and no, I haven't seeked. I'm in another really bad relationship, very toxic.
Yeah, that was my hunch, actually, because you haven't dealt with the roots yet. when you deal with the symptoms, patterns tend to repeat themselves over and over again. And until you get to the underlying causes of why you, first of all, seek out or consciously or unconsciously find people that repeat the same cycle in your life, unfortunately, these cycles will keep continuing. And the medication you're on, you know, if the intensity of the relationship gets bad or the abuse or whatever you want to increases, your possibility of the abuse potential of that medication you're on is pretty high. And those are the type of triggers that cause people to all of a sudden start using more of something to deal with anxiety. And then you're in a roller coaster that you won't be able to regulate or control your use, as you're calling it right now, because dependence will kick in big time because you're not dealing with the causes of the anxiety.
You're right.
And how old is Jules?
Huh?
How old are you?
I'm sorry.
45.
Where are you calling from, by the way? I detect a little bit of an accent.
California.
Are you? Okay, cool. Are you originally from California?
Yeah.
Okay.
What accent do you detect?
I don't know. Just something. I mean, I'm a foreigner too, so everything's an accent to me.
Right on.
Are you in Southern or Northern California?
I'm in the valley.
Los Angeles?
Yeah.
No, I'm in between LA and San Francisco, like Fresno County.
Oh, wow. Yeah. Okay. All right. Yeah, you're way out there. Okay. All right. All right.
Yeah.
Yeah. I mean, Parham just opened up a can of worms I want to explore here. And I'm very familiar with that area because I was in Bakersfield for many years. So one thing, Parham, it's interesting because she does not seem to. She's maintained this for 10 years without abusing it. That's always interesting. I'm going to put it in a colloquial sense. There's something a little nerdy about her because I'd be hitting that Xanax pretty hard by now if I had access to it, which I find interesting. And she's getting. Jules, have you sought help, mental health?
I haven't. I haven't.
Children?
Yeah, but he's of age. He's
What are you gonna do here?
I don't know. Like I don't know. I don't know. The stress.
Go ahead.
The stress and the anxiety it's just too much. It's just too much.
And you seem to stay in these relationships long term, huh?
Well, I'm trying to get out of the one that I'm in, but it's like I think it's a narcissist. I'm not sure, but then he kind of reflects it like I am, so I'm not sure.
What you say? You said narcissist, and then what did you say after that?
And then he kind of reflects it like I am a narcissist, so I don't know if I don't know.
Oh, that's very common actually with them. There's a few things for some reason they call you. One of them is narcissist, and then they tell you you're crazy. But for some reason they like to use the term bipolar. And
yes.
Yeah.
Yes. Yes.
Yeah. It has a very common theme and pattern to it. They'll first call you narcissist, then they'll say you're bipolar, and then they'll say you're manic. I don't know. Well, I'll tell you what. Why don't you do this? Do yourself a little experiment. Everything you're accused of, stand back for a moment and really meditate on what was just said, and then ask yourself, wait a minute, that's you. And if that works, you may, again, this is a non-psychologist litmus test, all right? If they do that enough, you might be dealing one. We'd love to keep track of you, and I don't know what, Parham, this is too short with all these people here, because I actually would like to dig into how she's doing, but can you come back and talk to us?
Yes, I can.
Yeah, come back and keep us updated. Is this your first time on the channel?
Yes, thank you for having me.
You're welcome,
Yeah.
Jules. There was last week, if you go watch our live stream last week, towards the second half of it, there was an individual that was sharing her story. She was from the East Coast. There was some similarities in her story and what you're talking about, and we spent a lot of time talking to her and coaching through her, and there was a lot of side chat that's very valuable to your situation. So go watch last week's talk and look at the chat that's going on. There's a lot of support that was offered and some solutions for helping you kind of get a little clarity in the situation that you're in.
Okay.
Perfect.
Does it make a
Yeah.
difference that the person that I'm with is using drugs?
Using what?
Substances.
Yeah, that's common too. Parham's absolutely right. Take a look at that one. We've done a couple of other things about trauma, I think. Take a look at all of those, and please come back and keep us updated, okay? And
Okay,
I'll do my best to look out. If you want, send me an email. I'll give you some resources at the very least. And the gal last week did send something, and there's a couple of online support resources I want to send her. But you sound like a wonderful lady or young lady, and this is a difficult situation. And keep us updated, okay? And watch those Xanax.
of course, yes.
Parham, anything else to add?
No, I'm good, man. Jules, come back.
I will, thank you.
Be safe, okay?
I will.
Bye-bye.
Thank you. Thank you. Bye.
Okay. Bye-bye, Jules. Okay, let's get Eli. Man, now these guys are just coming on. We're going to have to come up with a way to make everyone Eli, that's a cool ass name. I always said if I had a kid, son, I'd name him Eli, and there's Eli. Hi, Eli.
What's up, Eli?
Hey guys, hey, how we doing?
Good, man.
Brief synopsis: I'm Eli. I'm 30 years old. I'm a nursing student. I live in southeastern Ohio. Last year, I had my first bout of panic attacks, which led into a prescription. So I've been on 0.5 milligram of clonazepam for a year now, and what I see is just an overall diminishing of my drive, of ambition. I feel like I had underlying depression and anxiety for quite some time, and it's exacerbating those things. And like I said, I did have that underlying level of anxiety, maybe social anxiety, that I've had for quite some time, but never had developed in something so debilitating as the panic attacks that were coming seemingly out of nowhere starting last year in March. So right now I'm currently in nursing school. It's stressful. Right now I currently work on the weekends. I work 2 12-hour shifts in the emergency room at the hospital nearby. And, there's a lot of stress involved in the job and in school as well. And I have a doctor that's pretty cool, but not sympathetic to something like the Ashton manual, not sympathetic to like titration or really any tapering rather than just cutting. And I take 2.25 orally disintegrating tablets, and they're not scored. I don't know anything about cutting them or getting precision with them. I tried a taper of reducing 0.0625 every 14 days, and I seemed to do pretty well, but then some really stressful situations came up, and I reinstated back to the 0.5 milligram. I don't know. That's basically where I'm at.
Parham, you want to go first, or you want me to?
Yeah, sure. Real quick, Eli, when you said last year around March, you pretty much out of nowhere got hit with your first panic attacks and stuff like that. Last year around March was a very significant time for this entire world.
Yeah, for sure.
That's when COVID hit, and you're a nursing student, so you're in the front lines of pandemic. And if that doesn't rise one's anxiety, I don't know what will. However, I will tell you this, Eli, that you said that prior to that, you always had some underlying anxiety and some depression, and this pill seems to be exacerbating it a little bit. So on some level, that I always see the opportunity in every problem, man. If you want to be in the healthcare space and you're committing yourself to be a frontline worker, you want to be working in hospital settings and in medical settings, man, to work on that underlying stuff right now, because I'm telling you this, there is no other job in the world that's psychologically and emotionally draining than dealing with other human beings when they're not on winning streaks, when people are down and out, when people are struggling, when people are going through stuff. You need to be, if you want to have a sustained career in the field, if you want to be healthy and effective, and you want to work in these settings, you need to get to the underlying causes of this stuff, man. That social anxiety you talk about, that depression you talk about, it's always going to be there until you do something about it. And I'm not saying I do apologize that you're going through this because as a result of this pill, but this pill is actually bringing up some stuff that actually was already inside of you. So I look at this as a blessing and an opportunity to address this stuff, because you will be in about a year here working. Your school's going to be done. You're going to be full-time working. And then the sooner you resolve this kind of stuff, the sooner you work on this stuff, first of all, the less likelihood you'll be needing a medication for it. Second of all, you'll be more effective in your line of work. So, Dr. B, if you want to share on the Klonopin component, feel free to. But that's what I had to say, Eli. I look at this as an opportunity.
Thank you.
Eli, I can't help myself. I got to do my investigation. Can you answer me quickly so I can get to everyone else? But I got to know a few things. Number one, so are you in the accelerated nursing program?
I'm in an ADN program.
Okay. Okay. And Parham already nailed the significant issue. There's something from before going on.
Yes.
Now, is it panic attacks that he put you on the Klonopin for?
Yes.
Yeah. And you plan on doing emergency medicine nursing? You want to go work in the ER or?
No, I plan on being in the ICU for a few years, is getting enough experience to enter into a DNP program.
Nurse practitioner. Yeah. So either way, one of the things with either one of those, and I've spent years in both of those spaces, you're going to be doing shift work, okay? You're going to be doing 12-hour shift work.
That's what I do now.
Yeah. As you age, like Parham said, you're young right now, right? Whatever that issue was, now we got the benzo in there. It's brought that up. But your body cannot tolerate whatever toxic stress that was originally the cause of all this. As you age, it's going to pop out somewhere. As it happens, especially the ER crew and to some extent the ICU crew, they like to party and they drink, right? And you don't want to add that on top of this. So a couple of things. Number one, like Parham said, absolutely address whatever the underlying issue is. Number two, I don't want to tell you to fire your doctor or whatever, but you're on this 0.5 twice a day. Somebody somehow has to take, you got to find someone that's really comfortable with benzos. With benzos, you got to understand each person is different. I might switch you from Klonopin to Valium, and it makes a world of difference, and I can do a normal taper over time. It's a very tricky thing. You got to find somebody to slowly taper you while you address your mental health issues and get off of this stuff forever if needed. And it's early enough where I don't see you being dependent on this for life, right? It's been, what, a year, we said, last March, Parham?
Yeah.
So both of those things are critical. I feel a sense of urgency in telling you, don't sit on this crap. Do both of those things. Manage the medication correctly, and I know it's easier said than done. There's got to be somebody out there. And B, think of it like Parham said, as a blessing. Get the underlying issues addressed, resolved, mitigated, whatever. And then you can go on and live a happy life as a ICU nurse and nurse practitioner.
Yeah. So like I said, it's actually only a 0.5 milligram of clonazepam that I take a day, but even just reducing my dose in small amounts, I felt some pretty uncomfortable, not just uncomfortable. They were downright horrible, actually. And I live in a place, like I said, southeastern Ohio. It's Appalachia. It's very poor. There's not a lot of mental health resources around here. There's just not. There's not a lot of doctors that are sympathetic to this sort of thing or well-versed in this sort of thing. You're right. I'm sure there is somebody out there that can help, but it is very difficult in this area to find.
What about telehealth in your state? I mean, I'm sure if you branch out of your local region and you get on telehealth, you seem pretty savvy to be able to communicate with a doctor like this. So I wouldn't underestimate the value of finding a good clinician via telehealth. It has to be within your own state, though.
Yeah, for sure.
Yeah.
And like I said, my doctor's cool. He's just not down with switching to like a different method. I think maybe it's just because a lot of U.S. doctors are not well trained in benzo tapering or really knowledgeable about addiction at all, unless they get into it specifically. Because I'm not sure how much training you receive in medical school, but I don't think it's a super sufficient amount for the amount of addiction that we have in the country. So I don't use any other substances. I don't drink. I don't do anything else. So, yeah, you guys are right though. There's always been that. Maybe you're right in that I have in my aging, even though I'm only 30, that stress has built up and popped out because I feel the inflammation. I feel the stress. I feel that anxious state of just tension,
Yeah.
And so that's what my doctor suggested to me, is that I start going to counseling and then we start on a taper, but a taper of just like cutting these pills that are unscored and everything. So
That's not a bad idea. And whatever you do, let me give you a stark warning. Don't start drinking alcohol.
No.
Yeah, absolutely, because that's benzos or alcohol in a pill, and and keep us updated. We really love to see how people are doing because a lot of difficult scenarios come up. Please come back and keep us updated, okay?
Yeah, I appreciate it, guys.
Got it, Eli.
Okay, Eli, peace.
Thank you.
Okay, think we got a bay now. Oh yeah, it's a bay.
Hey guys.
What's
Can
up,
you hear me?
man?
Yeah, I'm good.
Hi, Bay.
I'm good. How are you guys?
We're good,
Can you
man.
hear me?
Yeah, we can hear you. Are you still
Yeah.
clean? Last week you told us you're clean still.
Yeah, 2 months.
Oh
2 months
man,
clean.
that's awesome, bro. Good
Mm.
job.
Mm. I actually went to my primary healthcare provider and I discussed the things that needed to be discussed. And I get tramadol from them when I need them instead of getting anything off the street. And
Okay.
now I'm tapering off.
Yeah, that's awesome, man. That's a big deal.
Mm.
That's a big deal. I definitely remember you.
And you sound great.
Yeah, thank you so much for the compliment.
Uh,
And I'm very grateful to you guys. You guys really helped set me straight towards a proper journey. We need a access to look forward to. So you guys helped me find that access, and I'm really grateful to you guys. Thank you.
Thank you, Abe.
it's our
Uh,
pleasure. Keep us updated too, Abe, okay?
And on the topic of benzodiazepines, I used to abuse alprazolam and clonopin, but now I've tapered them down to 1 mg Albrax and 2 mg clonopin orally disintegrating sublingual.
Awesome.
Mm.
Keep that up. And
Yeah.
we're really happy that you're well on your way, and keep us updated, okay, Abe?
Yeah, I will keep you updated and will follow you guys along for this journey. Thank
Thank
you.
you, man. Appreciate it, man.
Bye-bye. Okay, we got Gary, then we got Angie. Gary, what's up, man?
Hey, what's happening? Y'all hear me okay?
Yeah, we can hear you,
Yeah.
Gary. What's going on?
Well, I had a few questions since we're talking about benzos. Well, since you're talking about benzos, I figure I'd come on and, see if I can get in on the conversation. A lot of people actually stigmatize those of us with mental illnesses that are on benzos. And we awfully hear a lot, that we should only be on them for a little amount of time, or, it's stated here, and shouldn't be on them very long. And, or if you're a recovering addict, you shouldn't be on them, or you're not sober. So I was wanting to see what your all's opinion was, about that. And I could give you any type of background you need on mine. I currently am on benzos. I've been over 14 years sober off of opioids. So I just had a few questions, and just like to maybe another time when y'all have some time, or talk to you and see what you think, because I have a lot to talk about.
Actually, Parham, may I respond?
Absolutely.
On this? Gary, I'm really, really glad you brought this up, because this is a wonderful example of the spectrum. I had an attending that used to tell me, you get paid the big bucks because it's not the same button every time. And here's what he meant. So you brought that issue up. Okay. I have a couple of guys that I take care of with extensive mental health issues, bipolar disorder, substance abuse, et cetera. And they are doing absolutely amazing. But guess what? I think one of them is on 4 milligrams of Klonopin. Okay. I have so you got this medication, and the way we seem to respond to the prescriptions, just like everything else we do in this, in our society, everybody has to have it. No, whatever the drug is, whether it's Xanax, whether it's Klonopin, whether it's Valium, I don't care what it is. For a certain group of people, not only is it needed long-term, but it might even be needed in high dose. Every decision you make should be a risk benefit. So this guy is dysfunctional without it. His quality of life is crap. He's going into manic episodes. He's drinking like a madman, or if he's, mainlining some fentanyl daily. Okay, it's easy. If I'm going to put him on 6 milligrams of Xanax a day and 850 milligrams of Seroquel until we get the lipid thing straight, whatever, and that keeps him sober-minded and gives him quality of life, then you do that with extensive education for that patient of the risk and benefits and so on. And you always strive to minimize the medication. And so you brought that out for me, and I appreciate that, because every case is different, but not very few cases need the amount of drugs that people have been put on over the years. So thank you. And that's what I wanted to say about what you said, because it made me think of that.
Yeah, and I appreciate you actually saying that, because I couldn't tell you how many times that I get stigmatized on YouTube, especially with my channel. And I've been put down by other people in the mental illness community. I don't really call it mental health, because we all have mental health. Not everybody has a mental illness. I look at it differently. But I've been put down several times, because of what I'm on. And I don't, quite frankly, care to say what it is, how much it is, how long I've been on it. Like, I'm open to talk. You know what I mean? So,
Gary, the good thing about Dr. B and myself is we strongly believe, and that's why I think our recovery community here is so strong. Personally, as clinicians, and Dr. B is a doctor and I'm a clinician, we believe in the individuality of care. I'm somebody that would be considered clean and sober in the 12-step community, because I belong in that community. I will tell you this, Gary, that I don't care what a person is on or isn't on, as long as they truly believe and feel that they are clean and sober and they are working a program of whatever recovery it is for themselves, and they believe that they have regained something that's been lost, stolen, or destroyed, which is the definition of recovery, then, man, I'll pat them on the back and say, congratulations, thank you for being sober with us, man. And I really do mean that. The compassion that I have for anybody, regardless of what path they go on or how they choose to seek recovery, is completely individualized. I will never believe in dogmatic thinking. It's not my way or the highway. And anybody that thinks that way is missing out on an opportunity to help out human beings and help them recover together. So,
because the thing is like, I'm not even prescribed Xanax. I've been on for almost 3 years now. Before that was Klonopin. I take 2 milligrams 3 times a day. But I have OCD, schizoaffective disorder, which is bipolar and schizophrenia, PTSD, agoraphobia, generalized anxiety disorder. And with the 6 milligrams of Xanax daily, I also take lithium. So that's what keeps me from pretty much hurting myself or someone else, from being in a psychiatric hospital permanently, and being alive. So really, like, when I got clean and sober, I did it on my own, tapered. I was on over 25 pain pills a day, snorting them. And I was clean for about a year before I even went and sought treatment for my mental illnesses. But I've been getting treatment off and on for that since I was 8. So, I mean, I've been in this, this whole thing for years and years and years. And I just knew that because I had seen that y'all talked earlier, mentioned, shouldn't be given more than 10 days. And then Dr. B mentioned that, yes, some people are on it longer. So I was just trying to come on to get, to get more clarification, of that. So some people would know, hey, like you said a second ago, sometimes you have to be like, for instance, I'll be on this the rest of my life. I mean, it's just, I'll be on benzos the rest of my life. Even if I get to the root causes, which, as I said, I've been in it since 8. I don't want to go into trigger warning stuff, but I've been abused. I've been all kinds of stuff. It's on my channel, but you can't really get to. And when it comes to the chemical imbalances, schizophrenia, bipolar, you can't really fix that. You know what I mean? So there's a lot of misunderstanding, and a lot of people just think, oh, well, try antidepressants, which does help a lot of people with generalized anxiety. But you all know when it comes to bipolar and things like that, it can actually make those mental illnesses worse and actually can cause suicide. So they really have to watch giving antidepressants to those with bipolar disorder. So.
Absolutely. And we want to be aware of your journey. So every once in a while, come on and tell us, what is your YouTube channel? I'm just curious.
It's Bipolar Corner.
Okay, I'll check it out sometime. And every once in a while, come on here and update us on how you're doing. We'll always support you on this journey, and ask us any questions you have, Gary. We'd love to have you.
All right, I appreciate it. And y'all have a good night.
You're awesome, Gary. Thank you, bud.
Thank you. Let's get Angie on. I just saw something about compartment syndrome, and I can barely see it. Whoever wrote something about a concern for compartment syndrome, I'm pretty damn good at managing that too. In fact, I've done a lot of fascial releases. Maybe you should come on YouTube and ask about that. And if you really think someone has compartment syndrome, you better rush them to the ER. They lose the pulse, and then you're going to lose that extremity. Okay, let's get Angie on here.
Hey, Doc, remember, just quick, you said you have to leave at a certain time.
Sure. Okay, I feel bad, but I want to make sure everyone gets a chance here. We have Angie. I think that's the Angie I know. I don't know. I hope so, maybe.
Yeah,
Angie.
it is.
Oh, hi. How are you?
I'm okay. How are you?
You came on. You sound awesome. I hope you're awesome. Did you come on to tell me I suck?
No. I came on to tell you that from 30 milligrams, when you switched me over to Valium last May, I'm down to like 5.5.
Yeah. No, I follow your case. And what was more interesting was what was going on before. Which was it wasn't just a taper. It was particular hypersensitivity. And I actually thought you had an upper motor neuron disease when I watched you walk. And I'm pretty good diagnostician with a good respect for my differentials. And when I saw you walk, I'm like, I need to rule out upper motor neuron disease. And it was just all long-term benzo withdrawals, if I recall correctly.
Yeah, tolerance. I think I was in like tolerance.
Yeah.
Because once I stabilized on the Valium, I didn't feel like that anymore.
And you sound amazing, and you're and Alexis always updates me on you, and your voice is not crackly, and I know you gained weight, and you did you did great, and you kicked butt. Parham, she lives up in the Central Valley as well, and I don't know how she found us, but she came to us, and we found
you. I was desperate because I was having like panic and anxiety for 24/7 for a couple months, and I knew my doctor wouldn't help me, so I was just desperate on YouTube, and I found an old video that you did on talking about tapering people slowly off of benzos, and that's how I got a hold of you.
Oh,
that's awesome.
Well, actually through Nicole, and then you.
Oh yeah, you called Nicole. Good, good. Yeah, you sound amazing, and I know Alexis is doing a great job with everybody out there. And
Yeah,
yeah,
I'm
I'm so
talking
happy.
to her tomorrow.
You do? Oh, maybe I'll pop on and say hi as well. But I'm so happy you came on and said hello to us.
Yeah, me too. Thanks.
Thank you, Angie.
Oh, okay, Angie. Bye.
Bye.
Okay, let's get Lawrence on. Damn, I gotta go, guys. But let's. I feel bad. Let's get to Edra. Okay, guy Lawrence, talk to us, my friend.
Hi, Dr. B. Parham. I appreciate the wisdom that you both have, respectively. First time calling in, second or third time watching. Burned out for mental health work 10 years ago, anxiety, insomnia. Went on a half a mil of Ativan, have been on it 10 years, and it works, but just like every once in a while, I feel like, you know what, it's time to get off of this stuff. And the thing is, a half a mil of Ativan, I guess, isn't much, but I'm very sensitive to all kinds of different things. So for me, it's kind of like, I tried before I knew any better a few years ago. I just tried quitting cold turkey, and that was not good. And now I know why, because I found you guys and found some information about tapering. So I was wondering, my question is, and what happened was I was wondering, reading I forget the name of the journal or the manual from England, but she was saying like
Ashton.
Yeah, Ashton said that, you should switch to a longer acting. And I really struggled with that. Like, it's only a half a mil of Ativan. Why should I go on to another drug? And then I was talking it over with my GP, who's a really good guy, and he doesn't really understand tapering, but he's working with me. So he switched me over to diazepam and looking at the equivalents. And it's like, God almighty, I took like 2 milligrams of diazepam. I slept okay, but I was groggy the whole next day. So now I've kind of gone off the diazepam. I've still got some Ativan left. I've just gone back to tapering it from like a half a mil down to a third of a mil. Letting it dissolve in a liquid, right? So I just want to, like, what are your thoughts on going to the longer acting diazepam, which doesn't seem to be working, versus just chilling out, tapering down on the Ativan? Any thoughts on that?
Sure.
It's probably not. There's people that are going through much more than I am, but I just happen to see you guys are on the air tonight. So,
sure. Parham, shall I?
Of course, yeah.
So in general, okay, number one, Ashton just passed away, I think, a couple of years ago. She was 90 years old. I'm very familiar with the manual. I myself, I don't do the Ashton method. I do my own method, but it's a little mix of Ashton and everything else. As it turns out, I just looked at all of the international recommendations, guidelines, and they're pretty much what I do. Here's what I think about going from Ativan to Valium. I wouldn't necessarily. The only drug that the only one of the benzos I am relatively, I really push for cross tolerance and switch is Xanax. And also people often think Xanax is short acting. It's actually not that short acting. Xanax just crosses the blood-brain barrier very rapidly. And I don't like that. That's it. So in general, if someone's on Ativan, I have no problem staying on Ativan. Again, I don't do it. In fact, there's people I've tapered off of Xanax because for whatever reason, that was where we could land, and that's what they wanted. But necessarily going from Ativan to Valium, I wouldn't do. If I was really going to do that, I would do Klonopin. Oftentimes, it's clinicians' comfort. I just happen to be comfortable with all of them because I've played with all of them for so many years, and I'm okay with doing any of them. But you don't have to go from Ativan to Valium or even
Okay.
Klonopin. You can taper off of Ativan,
That sounds good.
in my opinion.
No, I appreciate that. That kind of confirms, like, it just sort of seems to make sense. Why switch to something else? I just continue with my taper, gradual, and I'm sure it'll be fine. And lastly, Parham, I called Dr. B's office, and I guess it was Nicole gave me your number. I mean, I can't find anybody up here who understands any of this, even for like a 15-minute phone call once every 2 weeks. I don't know if you're at a clinic or if that's something you can do, or can you deal with someone in Canada, or how would that work?
Can you shoot me? Can you call me one more time, please?
Sure. Yeah. Just tell me your number again, Parham.
949.
Yes.
903.
Yes.
6636.
6636. I'll give you another try.
All right, bud.
Awesome. Thanks, gents. Have a good evening.
Appreciate it, bud.
Bye.
Bye.
Bye. I remember Lawrence. Let's get David on, guys. I gotta bounce, but let's. I'm not gonna leave these.
You're hooked, doctor. You're hooked.
Well, every day my life is a shit show of being behind, and there were like 6 people out there waiting for me, and I think I just suck at planning my day. Lawrence, we're on David. Is that what we're on? Okay.
Yeah.
Hi, David.
How y'all doing?
What's up, David?
Kind of at an angle here.
Hi.
Is that better?
Yeah, you're good, man.
Okay, my story is long, but I know you don't have a long time.
Can you turn it up? I can't. Well, I don't know why I can't hear him. Can you hear him, Parham?
I can hear him. It's a little soft, but I can hear him.
Okay. Okay.
I can't. I'm on an iPad and I can't get it in there straight like that.
That's okay.
Okay.
Go ahead.
I got in trouble back in my late 20s. I'm 49 now, and I jumped on methadone because I had probation hanging over me, and I was not confident I could be clean for 10 years, and that's what I had hanging over me. So I have been prescribed benzodiazepines for well over 20 years, and I've been on methadone for 10 years the first time. Switched to Suboxone for 5, and then couldn't afford it. Went back to methadone because I had Medicaid that paid for it. Now I switched back. I came from 190 milligrams. Well, anyway, before that, my psychiatrist got flagged in some sort of a mandate a couple of years ago, and he pulled me off 2 milligrams twice a day of Klonopin. All right, I was on. It's because it was I was taking methadone also. Okay, and I understand the respiratory depression and all that, so I haven't been able to find another doctor. But when I tried to come off that cold turkey, I have had 3 psych ward stays for it because it's just absolutely miserable. And to be 100% honest, I have abused the medicine. I don't just take my prescription. And it's gotten worse since the last stay in the psych ward, because I've been getting them illicitly now, because it's almost as if they're making me choose whether I want to get high on dope again or I need my mental health. And it's not a matter of, I think maybe I could be tapered. I have general anxiety disorder that I believe is brought on by the medicine. Actually, I was put on. I didn't know what it was. I was feeling a little bad. I was in a bad relationship, and a psychiatrist prescribed me Prozac and Klonopin, and so been on it ever since. But now that I'm in Alabama, and it's just very, very conservative. Your doctors, my psychiatrist said they were getting put in jail. Okay, so he wasn't. And I did absolutely nothing but keep my takeouts. Everything was perfect until this happened. And when it happened, like I said, I had to make my mind up after I realized that I couldn't go see 15 psychiatrists and pay out of my pocket to try to find somebody that would prescribe it to me. Well, now I've switched to Suboxone again, which I know is not, it still has problems with respiratory depression, but I know it's not as bad because it's a partial agonist. But anyway, I probably am 6 to 8 milligrams Klonopin a day, and I've come off everything in the world, and that it's because of not only do you get every single withdrawal symptom you get from dope, from opiates, it messes with your head so bad during that time that if I couldn't put a plan together, I mean, I stuck a needle in my eye to make it stop. The first time I had a massive panic attack during this, and because I saw a razor blade, and the first thing I thought of was grab it. And I mean, just in all honesty, but I don't want to, you know, that's not what I wanted to do. I called the ambulance on myself and threw the thing out the door. So anyway, I'm trying to get to a point where I mean, I'm 49. I don't want to be buying illicit medication, but I don't know any doctor that would. I've never heard of a doctor start someone off at the level I'm already on and then tapering them down from there here in this state. I mean, it's just almost like an impossibility for me to even believe that you do that. And I'm so it's a blessing to hear that, but it's also, I'm jealous because I really would like, because I have very little hope that I can quit using. Because I made it when I have run out a couple of times from the dangers of getting it off the street. Psych ward I go, you know, because I can't, you know, and they keep me. All right, well, the last time they put me on Seroquel, and he kept me in 15 days to get it in my system, and then sent me to a medicated psychiatrist who immediately pulled it from me. That and my is a medicine for itching that is good for Atarac, I think is what it's called. And she pulled me off that. She pulled me off everything but Prozac. And the doctors kept me 15 days to put me on this medicine, and she just jerked me right off.
David, sorry, let me just get a couple of things straight. And I apologize, I'm a little rushed here. No problem. You're taking about 8 milligrams of Klonopin, and it's bought off the street daily. Is that what you said?
Yes, sir.
And then you're on subs, and I didn't catch the mental health stuff, but and so that's equivalent to somewhere between 14 to 20 milligrams of Xanax a day. And your question is, how do you find someone in Alabama to put you on this list?
A reasonable dose, or to get me all the way off of it if possible. I mean, that's my thing is that, you know, I only swapped back to Suboxone Friday. So, you know, I haven't had a chance to call to try to find another doctor that might work with me with Suboxone, because I have had Suboxone doctors write me my Klonopin, you know, so I don't understand how it all of a sudden I've never had any respiratory depression problems at all, and I was on 109.
No, there isn't.
I'm talking about the methadone, though, but I don't think there's any at all. Go ahead.
No, for clinical purposes, there's a look. If I may, real quick, and Parham, if you can, and I apologize, I got to go on. You can come back on next week to continue this.
Yes,
Number one, I don't know if there's any doctors out there that will do it at that level. We just did a young lady who's super cool. She actually came out from Florida, and she was on 30 milligrams of Xanax a day, and she's staying with us, and about 45 of Adderall, and we've got.
I've been down that road too.
Yeah, I think we've got her down at month 4 to, I don't know, she's down to 8 milligrams of Klonopin a day right now. So you can find somebody out there, and you're going to have to, but you don't want to keep doing what you're doing. That's what I have to.
I'm on Suboxone. I'm praying that I can find somebody that's more aware of the lack of respiratory depression compared to methadone.
Yeah, and if I
Am I
may,
right?
I want to. Parham has any closing thoughts, and I apologize, David. We can continue this if you have more questions next week because
Yes.
I have a clinical application. But Parham, do you have any closing thoughts for David on this?
No, I'm okay. I listened to everything you said. Next week, I'll be able to provide some follow-up. I know you're short on time. I just want to honor that, Doc.
Okay.
Thank you
They're
all for
knocking.
letting me be on.
David, if
We'll
you
be
want to
with you, David. We'll be here.
Thank you very much.
okay, and we'll do that. And let me, guys, I'm super late. Bye, David. Hey, guys, thank you everyone for coming on. This was a really cool topic, and I think there's still a lot of questions out there. I don't know what we'll do next week. In fact, people can come back and ask about this. Parham, I want to tell everyone out there, one of the things I was, and I want you involved is I wanted to discuss, I thought we'd do physically, since you're an athlete as well, and I have this team that is really great people that are personal trainers and dietitians and all that stuff, and I wanted to bring them on and generate a discussion about physical health and diet and recovery. What do you think of that?
I love that, man. That's like my passion.
Great. So we're gonna bring him on, and his name is Ken. He is a rock star. Him and his wife basically have a program, and I'm not going to bring anybody that I don't have any respect for. I have tremendous respect for this guy, and I want to bring him into this, and the three of us can have a discussion about that next week, guys. Cool. And guys, thank you so much, Parham. Give your thoughts. I'm sorry, I got to close this because I have clinical obligations, but Parham, give us your closing thoughts as well.
No, this is great, man. There's a lot of chat. We'll be back next week. Please, if you had some questions or if you wanted to talk to us, come back next week and talk to us. We will be here, guaranteed.
Okay. TikTok, same to you. Get your butt over here. Hey, guys out there, if you're new, please like, subscribe, go on our Patreon. We don't get paid for any of this stuff or the videos. For as little as $3 a month, you can keep us going and at least pay for the production for some of the YouTube videos, but we're always going to be here no matter what. We're committed to you. Peace, and see you guys next week. Parham, thank you so much for joining me. Your contribution is always so deeply appreciated, and I'll see you soon.
Thank you, bud. Appreciate it.
All right, let me kill. There's our YouTube, and let me do TikTok. Bye-bye. Get your butts on there. I saw some great questions on here, but I can't see it. Thank you, guys. Bye. Okay, Parham. That was great, wasn't it?
I think you're still live on YouTube, by the way. You might want to get off. You're still live on YouTube.
Yeah. No, I see it. Yeah, we got to do this one again, Parham, because there's so many. Bye, guys. There's so many questions, and hold on.